Eastern time. I think it's going to work out perfectly, which is really rare and unusual, so it's a good day. Yeah, so hey, thanks for inviting me, Bill. I'm really glad to be here. It is awesome to be doing an in-person conference finally. This is actually, I think, the second or third one I've done since, what's that thing called? COVID. Kind of tripped us all up. But this is the first one where we're not all wearing masks. And it's great to see all your faces out there. Now, be careful, because without a mask, if you make faces at me, I will see you. But I won't call you out. I know you have 2 years of history where you've been making all kinds of faces and nobody can see them. Now, if I see you wearing sunglasses, I know you're rolling your eyes at me, and then that'll have to call out. So thanks a lot, guys. I really appreciate the opportunity to be here. Before I start, who's a perfusionist in the room? Can you raise your hand? Whew, a lot of y'all. I know, perfusion.com, I got it. Any nurses here? Any ICU nurses? Respiratory therapists? I see, is there an ICU finger back there? Did somebody go like that? No? RTs, no RTs? And then how about, RT. Good to see you, all right. Physicians anywhere? Probably a couple, right? Somebody's gotta buy the drinks tonight. Steve Conrad's gonna buy the drinks tonight. I see Steve over there, so awesome. Well, yeah, so as Bill said, my name is Phil Mason. I'm the Adult ECMO Medical Director at Brooke Army Medical Center. I gave Bill a title a while back that had something to do about not going through the pharmacy, and Bill, I changed it on you just a little bit, buddy, but the content is the same. We're gonna talk about ECMO 2.0, how do we get patients awake, and through the process of doing that, we are going to de-emphasize using medications because they are really part of the problem, not part of the solution. Okay, so everybody had disclosures. I have no financial conflicts of interest. I have a ton of financial conflicts, but they're not interesting. ECMO, as you all know, is a lot of off-label use of equipment. Everybody here knows that. And then I have this unique disclosure that the rest of the people don't have to make, which is I work for the United States government. And they allow me to do so many things on their behalf, really, really difficult things, all sorts of things. But after all these years, 23, I'm retiring next month, after 23 years, they don't trust me. They don't let me speak for them because they don't trust me. But the feeling is mutual, so I think we're probably in a good place there. Let's get started with the content here, guys. Thanks for having me. Well, look at this slide. You guys have all seen things like this before. A lot of you are familiar with the concept of ECMO 1.0 versus ECMO 2.0, right? ECMO 1.0 was, let's see, what was it? High anticoagulation levels, older equipment like roller pumps and silicone membrane oxygenators, mostly veno-arterial ECMO, even for respiratory support. All these sorts of things. But one of the things that really typified ECMO 1.0 was deep sedation and a complete lack of mobility, right? The thought of getting those patients out of bed really was unthinkable. Fast forward, and ECMO 2.0 has a lot of things changed from that time, but the main thing that typifies it is mobility, awake, rehabilitation, up to and including ambulatory patients. That, for me, is really the most defining feature of ECMO 2.0. Now, 10 years ago, this stuff wasn't happening, or was maybe in a very small number of centers. But over the past 10 or 12 years, it's become more common. There's a lot of centers that do this. These are my patients, but there's plenty of centers that are doing this. There's some centers where they're not doing any mobility at all, and then most of the people are probably somewhere in between. Let me let you in on a secret coming from a program that's really aggressive with mobility. These are my star performers. I didn't come here to do ECMO show and tell so that I could show you the patient that I never got awake because they started coughing and getting agitated and got resedated and got in that cycle. So these are the really nice ones. I'm going to talk about how we get there. How do we get to ECMO 2.0, starting from this? How many people have ECMO patients that sign into the hospital through outpatient surgery and they show up for their elective admission for an ECMO run in the ICU? So they're clear-headed, they're physically strong, they're nutritionally replete, they're not volume overloaded, and this is going to be a nice smooth run. That's not my program, that's not your program, that's not anybody's program. Particularly with respiratory failure patients, which I'm going to focus on, but really all the ECMO patients, we start off in a deep hole. A lot of them are prone and paralyzed, particularly for respiratory failure, as I said, so they're very deconditioned. A lot of them are in restraints. They've been marinated in that medication you see on the left there, Versed. They have brain dysfunction, delirium, and so we start off in a really big hole. And that's our biggest barrier that we have to getting patients awake and mobile. So let's talk through a little bit of a systematic approach on how we can conquer this problem. Because you're mostly perfusionists and you're all ECMO-philes, as I call it, as opposed to ECMO-phobes, I'm going to focus a lot on ECMO physiology and management. How do we use the ECMO circuit correctly to maximize our chance of success? Then we'll talk a little bit about management of delirium, less so about anxiety, but they overlap a lot. And then we'll talk, finally at the end, just a little bit about physical strengthening. Though I have to say that's the easy part. If you can deliver a patient who is awake and adequately supported with ECMO, I guarantee you your nurses and physical therapists, they will get the patient out of the bed. They aren't the problem, you are. So we'll work through that. And as we go through this applies to all the ECMO populations out there. And I know as a perfusion-heavy group, there's probably a lot of VA ECMO in this group. I'm going to focus a lot on respiratory failure because that's where ambulation and mobility, I think, really matters the most because the runs are long. But this applies to pretty much everything. With respect to ECMO support, we're going to first talk about mobility with femoral cannulas. Prepare to have your mind blown, or prepare to be bored, I guess, depending on what your program does. Briefly, I want to talk about mechanical support of the right ventricle. A little bit about cannulation specifically, where does the drainage cannula need to go, and how does that set you up for success or failure? And finally, we're going to talk a little bit about hypoxemia, the physiology on veno-venous ECMO, and why you need to interpret it in context so that you don't terminate all of your sessions because of hypoxemia. The picture on the left upper side there has been around for a long time. You guys have all seen this. This is off the Mackay Getinga website, the advertisement for the Avalon cannula. Now, we have the crescent now, and I didn't want to favor one over the other, so the image on the bottom left is actually from their website, and I merged them together as if it's one graphic, just to show my neutrality. And then the patient on the right, I don't know the story on this patient, but he's very iconic. If you look about ECMO ambulation, you'll see it. I know the picture originated with Chuck Hoops, but really a guy who kind of typifies the dual lumen cannula and what it did for ECMO. When the Avalon cannula came out in 2009, it was absolutely revolutionary, and it opened the door in many ways to ECMO 2.0. Prior to that time, patients either had femoral cannulas, most of them, and the thought of walking a patient with femoral cannulas was really just foreign. Okay, so that was the limiting factor, and then some of them had central cannulations with open chests and were limited in that way. But this device really changed the landscape and got ECMO mobility on the radar. The thing it also did, though, is to let all of us come to believe that it does facilitate mobility, but we have come to believe that it's required for mobility in a lot of programs, okay? And that's something I want to talk about briefly. If you're in a program that requires a dual lumen cannula to get out of bed, I need you to adjust your thinking. We have to get past that if we're going to get all of our patients mobile. Here's just a few of the case series that are out there that describe mobilizing patients with femoral ECMO cannulas. The one on the top left is from 2014. It was 8 years ago, a good long time ago. That's from Columbia University. That's a big paper on ECMO mobility. They did not all have femoral cannulas, but some of them did. And all the rest of two of these papers actually specifically cover femoral arterial ECMO cannulas. Does that give anybody heartburn? Make anybody nervous? I think so. I'm looking around the room. You're too nervous to nod your head. I'll nod for you. It does. Okay. So you have got to adjust your thinking and recognize that that's a safe practice. Now, I've talked about it. I've shown you some pictures, shown you some of these case series, at least the titles of them, that moving patients with femoral cannulas is safe. Now I need to give you a visual so that you can walk out of this room and never forget it. And you can go back and preach it to the people you work with. Now, I have to warn you, the images you're about to see may be disturbing to some audiences. This is one of my patients from about 4 years ago. And you see him lying supine there. We use a recumbent bicycle sometimes for patients who are ready to do physical therapy, but don't yet have the physical strength to actually stand up. A bicycle is one of many ways, but it's very effective. And you can see he has a FEM ECMO, VV ECMO configuration there, and he's just chugging along just fine. The earth did not stop spinning, neither did the ECMO pump, by the way, and everything went fine. Okay, so take that image with you and realize, I don't care that you have your patient try to bicycle with femoral ECMO cannulas. I do care that you're willing to get them out of bed and let them walk. I'll tell you a graphic I wanted to put in here. I tell you guys everything. It's like we're best friends. I had this patient that used to sit on the bedside toilet, leaned over with his knees or his elbows on his knees on the potty with his femoral venous ECMO cannulas. And I asked him once, I said, Chester, please, can I take a picture of you pooping? Because I think it will help to deliver my point to people I speak to. And he said no. I figured if I asked him again, it was going to get weird. But that image is forever burned in my mind. So look at me and you can imagine this is a safe practice. All right, move forward a little bit, but stay on the topic of cannulation. This is a brief little topic I want to touch on. Speaking specifically about respiratory failure patients now. There is a subset of patients where no matter how great your VV ECMO circuit is, no matter how well it flows, even if you can get the blood gases perfectly normal, there's a subset of patients you will not succeed in mobilizing because gas exchange was not their main problem. It was pulmonary hypertension and right ventricular failure, okay? This occurs in ARDS. You know, it's fairly common. COVID-related ARDS, I think we all would agree it's more prevalent. It's a major problem. And also your interstitial lung disease patients, bridge to lung transplant, et cetera, those patients are not limited by hypoxemia sometimes. They're limited by severe pulmonary hypertension and right ventricular failure. So if you are failing to mobilize the patient can't tolerate PT, and you're not able to get out of bed, that's a question you need to ask. Plenty of medical management strategies for right ventricular dysfunction, for pulmonary hypertension, IV therapies, inhaled therapies, there's even oral therapies. And you know, they're only modestly effective. And if you're sitting on the beginning stages of a long ECMO run, they're not going to get you there. So if RV dysfunction is the problem, you need to move pretty quickly to mechanical support if you're going to be successful. Two good options here, classically, is what you see on the left there. That's drainage using a arterial cannula advanced through the right IJ into the right atrium, and then returning through a graft sewn on the right subclavian artery. Many of you are familiar with this technique to some extent because of your bypass cases in the OR. The technique's a little bit different. Matt Bacchetta really was facile with this and pushed it and has kind of a specific technique. But it's an effective way of supporting the right ventricle and bridging patients to transplant and still able to get them up and walk. I just put that diagram in there. Remember that guy I showed you that was standing up a few slides ago? When I found this article, I just had to put, it's the same guy, right? That's just an image of him there. More recently, there's a new technique to do this, which is the Protect Duo. So another way to provide mechanical support to the right ventricle as well as gas exchange support. Still probably finding its place and where it's going to fit in, but I can tell you, as you probably all know, there's at least one group, or two that I know of, that have been very, very aggressive with this in all their COVID patients, not even waiting for RV failure to develop, just doing it empirically. They've been very successful. Probably a lot of reasons for their success, but this early approach to RV support might be one of them, okay? So you can walk with femoral cannulas, and if the RV failure is your problem, VV ECMO is not going to solve it. You need to escalate quickly, or that patient's never going to get out of bed. Okay, so before I start on this slide, can I just ask you to please excuse the ungloved hand? This is an animal experiment, and you can look. It's not my hand. Look, everybody, it's not mine. So please excuse that. But I want to talk a little bit about how we insert the drainage cannula and how this one little fact can be really important to your success. Most of the time in respiratory failure patients, we start off anyway, draining from the inferior vena cava that we've accessed through one of the femoral veins. And it's important to remember the inferior vena cava is different depending on what level you're talking about. It's a different structure. Down low, it's a really collapsible, thin-walled structure. Can be, very easily collapsed. So if you put a large cannula inside of its lumen and apply negative pressure to it, it's very prone to collapsing. And it glues onto that cannula the way saran wrap would glue onto your face if you were trying to breathe in. You can see in this video here, I don't know if it projects really well, but you can almost see where the vena cava is being sucked into the side holes of that multi-stage cannula. Now, this is an animal. They're pushing the circuit really hard to make a point. Okay, but the vena cava is very collapsible at that point. A little farther up, where it goes through the liver, it becomes the intrahepatic vena cava. There, it's almost not even a vessel. It's integrated into the parenchyma of the liver. So it's very rigid and stented open and much less prone to collapse. So we're going to be far better off if we drain blood from this part of the vena cava than from the other, from the lower portion. Now, if your patient's going to stay sedated and lie in bed, it doesn't really matter. It just doesn't matter. But wake this patient up and have them start doing some deep belly breathing. Let them get a little bit ventilator dysynchrony. Let them cough a few times, and you're going to find this chatter is very prevalent in patients who have drainage cannulas positioned really low. And you're much more resistant if it's up in the intrahepatic cava. A little bit more on that same topic here. That's a multi-stage venous cannula you guys see on the left. Everybody here knows what that is. It still has a dilator in it. But it's got some side holes pictured there. The picture next to it is a simulation study that used MRI to detect fluid in motion, okay? And they have a model of a multi-stage venous cannula there. The base is at the bottom, the tip is up near the top, and everywhere you see a black arrow is one of those side port holes. So within that cannula, where it's dark black, that's where the most fluid movement is, and it gets more gray as you go up. So what am I telling you here? There's very little flow from the upper holes, the far distal holes on that multi-stage cannula. It's mostly through the lower holes. Here's another way to make the same point. This is a 3D reconstructed CT scan. I got this out of the medical literature. Is there any surgeons here or anybody that's really good with anatomy? Or just somebody remind me, there's not a blood vessel that takes that path of that left femoral cannula, is there? I can't remember anything that looks quite like that. So what's happened here is this femoral drainage cannula from the left side has exited the vascular space there in the pelvis. And you can see the side holes, right? Like that lowest one might be in the vascular, it probably is. That one may be in the vascular space, maybe. All the rest of these are in the retroperitoneum. Their point in publishing this was not to talk about ECMO cannulation complications, though that would be a doozy if they were. The point they made is this circuit worked just fine. The circuit was flowing just fine because the drainage was never from those distal holes in the first place. It was from the more proximal holes, okay? So have I convinced you that most of the flows through the proximal holes? I can't move forward until I have. All right, keep that in mind and look at this x-ray of a patient I took care of. This is a hospital I moonlight at, and I got called to see this patient. They kept asking for fluid bolus after fluid bolus. They kept telling me the patient, it's chattering. So finally I go over there to see the patient. And the patient had a KUB in the radiology viewer from earlier in the day. And I just took a look at it. And you see that multi-stage cannula coming from the left there. It's kind of hard to see, I'm sorry. But look at these upper holes on this cannula. You can see the gaps where the wire wrapping is eliminated for the gaps there. That's down in that collapsible part of the IVC that I was telling you about, right? It should be, the liver's way up here. The tip of this cannula should be up somewhere around the level of the diaphragm or even into the right atrium. So that's a problem. Here's a bigger problem. Remember those holes where all the flow occurred from? I don't know if you guys can see them really well here, but they're where those arrows are at. Those holes are actually in the iliac vein, which is far, far smaller than the vena cava, okay? So what I'm telling you is, at this situation, they're gonna call you, all day long for more fluid. Somebody's gonna start talking about, oh, we need a second drainage cannula, we have drainage insufficiency. Well, you either need a second drainage cannula placed or you need the first one to be placed correctly. Now, this is easier said than done, but for the use of even surface echo and ultrasound, there's a lot of ways to get at this, but to make sure the cannula is inserted deep enough. And again, wake your patient up and have them start coughing, and that cannula is going to chatter nonstop, and your progress is going to be halted. All right, that's all about cannulas, but I'm going to stay on the topic of ECMO here. Just a little bit of physiology of ECMO. Most of you probably know this. If that's the case, it's a refresher. Those of you that don't know it, it's super important, so pay attention. That is not a set of lungs with ears, by the way. I know it may look like that. That's the right and left side of the heart on each side of the lungs there. Let's look at normal physiology. So we have oxygenated blood coming out of the left heart. It goes to the periphery where it's deoxygenated, returns to the right as venous blood. As it crosses the lungs, if the lungs are normal, then the blood becomes oxygenated as it goes across. Pretty simple. I sure hope this is what's happening in all of us right now at this very moment. All right, these lungs are a little grayer. And this is an ARDS situation. And there's not a lot different here, really just showing you that, in this case, the lungs are less effective at oxygenating the blood, so it comes out slightly desaturated. You've got some arterial hypoxemia here. I don't know what that saturation is. I just chose that dark color of red from PowerPoint. But let's say the arterial saturation is maybe 75% here. So we decided to put this patient on ECMO. Let's see how that looks. So put an ECMO circuit in there. I put a block across the lungs to tell you they're not working. That's not always the case, but for this argument, let's assume there's no native lung function left. The blood comes out of the left heart, becomes deoxygenated, but as it goes to the ECMO circuit, it becomes 100% oxygenated before it ever reaches back to the lungs. So this is an ideal situation on ECMO. As it goes across the lungs, it doesn't matter that there's no native lung function because the blood's already oxygenated. So let's put some numbers up here to help us understand what's going on. In this patient, the cardiac output is 5 liters per minute. Nice normal cardiac output for somebody that's just hanging out at rest. That means that the total venous return to the heart is 5 liters per minute. Does anybody want to guess what I'm going to make the ECMO flow? 5 liters per minute. ECMO flow is 5 liters per minute. And the O2 transfer, you all know how to calculate this, most of your perfusionists. The O2 transfer in that membrane lung is 300 mils per minute, we'll just say. Okay? So this is a really good situation here. If ECMO always worked this way, it would be a pretty easy technology to deal with, right? If the patients were always 100% saturated. But that's not what happens. In this example, the cardiac output is now 10 liters per minute, which means the venous return is also 10 liters per minute. What's the ECMO circuit flow going to be? I mean, you can turn it up as much as you want, but it has limits. Let's say the ECMO circuit continues to flow at 5 liters per minute. What happens to that extra 5 liters of blood every minute that can't go through the ECMO circuit? That blood bypasses the ECMO system, goes straight to the right side of the heart, and it becomes an admixture there in the right atrium. So what you end up with is some significant arterial hypoxemia, even though you're on veno-venous ECMO. everybody seen this before? This is super important. What's also important is that the gas transfer in that membrane lung is still 300 mils per minute. If that was adequate for the patient 10 minutes ago, it's adequate for the patient now. Okay, the blood is less saturated because the cardiac output's elevated. At the end of the day, this arterial hypoxemia does not necessarily mean that there's tissue hypoxia. It's really important. And if you understand that, you'll be a lot more comfortable pushing through and trying to do rehabilitation on the patients, even though the oxygen saturation is low. Because you know, as long as that ECMO circuit is flowing, and you can calculate the oxygen transfer, I know you guys do this all the time, if it's adequate, then the oxygen transfer is adequate. And for the most part, even pretty significant hypoxemia does not tend to be a problem for the veno-venous ECMO patients. Now, there's a lot of debate in ECMO circles on what to do with this, so I don't want to open that Pandora's box. But I will say in some situations, the oxygen consumption does go up, right, because now you're trying to exercise the patient. And we need a little bit of guidance on what to do there. So to learn that, we're going to travel over to Nepal, to this place called Mount Everest. This is a really cool, fascinating paper that was in the New England Journal some years ago, and it looked at 10 people who climbed Mount Everest. And on the left there, you can see they measured arterial blood gases at varying levels along the way. Obviously, when you climb Everest, it's a progression up that altitude. You don't just go straight to the top. Now, on the right-hand side, you see the blood gases from 4 subjects at the summit of Mount Everest, the highest place on Earth. No kidding, they all made it to the top, but these are the 4 people that were present when the Sherpa was available to run the lab sample back down the mountain. That's what they said in the manuscript. Can't make these things up. So let's look at them and see if we can learn how to deal with hypoxemia in the face of having to do exercise. Well, first of all, yeah, they're pretty hypoxemic. What's that PO2 there? It's about 25. Arterial PO2 is 25. Oxygen saturation mean of 54%. Anybody getting heartburn yet? Whew, man, right? And these guys are walking up the side of the tallest mountain in the world, carrying a backpack, mind you. Pretty impressive. But they're not anaerobic. The lactate's 2.2 on average. I mean, it's a little bit elevated, but that wouldn't surprise you for anybody exercising. Pretty remarkable. Can y'all read that? Can anybody see what the mean hemoglobin in the patients was? It was 19. It was 19, right? So that was their compensatory mechanism. Now, man, you want to talk about a Pandora's box, go to an ECMO meeting and talk about what the hemoglobin should be. Dr. Bartlett's not here, is he? Am I safe to continue, guys? Okay. Okay, but I'm not telling you I push hemoglobins to this level in any of them. I've never been to 19. Most of my patients have a hemoglobin that is similar to all my other ICU patients, somewhere between 7 and 8. However, there is a subset of patients that are pretty hypoxemic. I can't get them out of bed. We're not having success exercising. In that case, the climbers of Mount Everest would remind you that if you just push the hemoglobin up a little bit, you will get a greater oxygen delivery for the same oxygen saturation. And these curves just show the content of oxygen content of arterial blood at 3 different levels of hemoglobin. And you can see as you go from hemoglobin of 7 to hemoglobin of 15, you basically double the content of the oxygen content of the blood. Does that make sense? So we have a way. For the most part, we need to just let hypoxemia be. It doesn't always indicate a problem. If we are up against a wall and we think there's something to do, we still don't need to cancel physical therapy and keep the patient sedated. We can augment the hemoglobin and overcome it that way. All right, that's enough physiology. I'm going to change gears just a little bit here. I'll let you guys all read that for yourselves there. Well, I'll read it to you. Delirium is a disturbance of consciousness with inattention accompanied by a change in cognition or perceptual disturbance that develops over a short period of time. All right, show of hands and be honest. How many of you had this state last night at the pool when you were drinking? Anybody? Come on, guys. Nobody had this? Bill, are you sure they're all perfusionists, man? They said they were all perfusionists. I'm a little bit surprised here. No, I understand. How many of you have this confusional state right now? Your blood sugar shouldn't be low, but you could be nodding off after lunch. Okay, so delirium. I want to talk about that for a few minutes. It's really important. Delirium occurs in up to 80% of mechanically ventilated patients, and it tends to associate with higher severity of illness. What I'm saying is if you put a patient on ECMO, the likelihood they have delirium is probably at least 80%. It's really high. It's associated with increased mortality, is associated with increased length of stay, and increased hospital costs. So everybody in medicine, no matter what your role is, should really care about this, including hospital administrators, all the way down to the folks at the bedside. The reason you need to care about it as an ECMO practitioner is because it is the central feature in this thing that I'm going to call the pathway to failure. And this is a little bit about similar to what Bill was kind of talking about in the introduction there. So let me walk you through the pathway to failure. It's not something I would normally walk somebody through, but by walking you through it, maybe you can avoid it. As I do this, think back to your ICU and tell me if you've ever seen this. Okay, the patient is sedated. They probably have some delirium because it's really common. And on rounds that morning, the plan is, hey, we're going to get this patient awake. We got to get them up and get walking, right? So you lighten the sedation. What happens to the patient? They become agitated. You know exactly what I'm talking about. They're squirming. Their heart rate's 130. They're trying to pull out devices. They're struggling against restraints. And when they get agitated, their oxygen saturation drops. They become hypoxemic. Maybe because the cardiac output is up, right? We talked about that. Maybe it's because your ECMO circuit won't flow anymore. Maybe the cannula is sitting low, or even a perfectly placed cannula will only tolerate so much, right? So through a kind of a confluence of factors, the patients become hypoxemic. The nursing staff responds, well, the physician staff too for the most part, responds by resedating that patient in response to hypoxemia. And this cycle goes round and round. Now, resedating that patient is a fabulous short-term solution if it's the hypoxemia that you were trying to treat. Congratulations, you've done a great job, and it's going to get you through the end of your shift. It's not going to get your patient out of the hospital. The problem is that the medications that we use to sedate the patient cause delirium. They cause delirium. There's a lot of things that cause delirium, but the medicines we use to sedate the patients are one of the big culprits. So we end up in this never-ending cycle. Has anybody ever seen this in your hospital? This is super common, right? And we've got to find a way to break out of this cycle. Now, what Bill was talking about earlier, the same thing happens, and I don't have this in this cycle, Bill, but we could add it in. The patient gets a big old wallop of propofol and a bunch of fentanyl because they're wild and crazy, and then the MAP is 43, right? And then somebody gives a liter of fluid and the pressure doesn't come up, so now they're back on vasopressors, and we do that little up and down dance. Somewhere along the line, we got to break out of this, guys. Let's talk about how we're going to do that. Before I do, I want to point you to a couple of resources. Delirium is a huge issue. There's entire conferences bigger than this on ICU delirium alone. It's super important. If you're an ECMO practitioner, an ECMO medical director, ECMO coordinator, anybody involved in the field, you might care about this. There's a few resources you should look to. On the left is ICUdelirium.org, kind of like perfusion.com, right? You want to know about perfusion? Go to perfusion.com. You want to know about delirium? Go to ICUdelirium.org. Just click on that little link for medical professionals. There's a ton of great resources there that will teach you and teach your team, teach your patients and families about delirium and a lot of strategies to cope with it and how to deal with it. So that's a great resource. On the right there is the sedation guidelines that came out from the Society of Critical Care Medicine about 4 years ago. A real big component of these guidelines are how we can deal with delirium or avoid causing delirium in our patients. So I refer you to those. I can't offer you an in-depth discussion of delirium because I'm not that smart on it myself, and it's a whole conference worth. But I will talk about a few specific things that I think really apply to our patient population, that being the ECMO patients. One of the tools that you'll find there, by the way, is this. This is called the CAM ICU, or it's Confusion Assessment Method -ICU. We're used to seeing the subtype of delirium we call agitated, where the patient is really mobile and it's obvious that something is not right. Actually, the more common presentation is hypoactive delirium, where the patient is confused, but there's not physical manifestations. In those cases, you have to screen for it, and this is a way to unmask that. So that's an important thing. So let's talk about a few approaches on how we're going to deal with delirium. And the first thing I want to do is talk about sedation, okay? This is really important, guys. Some of y'all were around in the Reagan years. Do you remember Nancy Reagan's approach to the drug epidemic? It was just say no, right? So just say no is also the right approach to ICU sedation. Just say no. Now, am I pushing it a little bit here? Maybe. But you don't know if you don't try. I'm going to show you another video. This is part conference lecture for me and part ECMO show and tell. Here's one of my patients. Look at his endotracheal tube in his mouth. He's on no sedation. This guy has a subclavian artery ECMO circuit. Watch him stop here, adjust his endotracheal tube. Nurses are nervous right now. He gives the nod. I'm good to go. Let's do this, guys. Okay, this guy's on no sedation. He's got an oral endotracheal tube. Now, most of my patients we push to extubate pretty early, actually, and if we can't extubate or choose not to for whatever reason, we go to a trach. I don't honestly recall why this gentleman had this ET tube 2 weeks into his hospital course or his ECMO run. But what I want you to see is he's on no sedation whatsoever. He is as calm and cool as a cucumber up walking around with an oral endotracheal tube. Can all patients do that? Absolutely not. Absolutely not. But most of them never get the chance because we don't try. We assume, there's this, y'all have this drug, it's called, it's a long word, it sounds like two words together. Oh, it's called Propenfent. You guys have that Propenfent? It's like one drug in my hospital. And every patient that comes in gets put on Propenfent. And I ask, why are they on that? And nobody can answer. It's just a reflex that we do that for all the patients. So the first thing you need to ask yourself every time, does the patient need sedation at all? Okay, ask that question. The answer may be yes, but it may be no. And even if it is yes, we should be trying to minimize sedation. So we unfortunately, they can't all do this. We're going to have to use some sedation. Let's talk about how we can do that best, most effectively. The Just Say No moniker still applies to this medication called lorazepam, better known as Ativan. There were no nurses here, right? Okay, good. Because I always tell people, I'm like, listen, save the Ativan for the nurses. Please don't give it to my patients. Okay, there are a number of things that we do in critical care medicine, sedation practices and otherwise, that are associated with causing delirium. One of the very strong associations is continuous infusions of lorazepam or Ativan. You all probably see this in your hospital. Maybe more commonly it's Versed. This study looked at Ativan, but Versed or midazolam probably has the same issues. So I would tell you, I don't recall the last time I used a continuous infusion of Versed or Ativan in any of my patients. I just don't do it. It's very good for status epilepticus. It's not bad for alcohol withdrawal. It is not for ICU sedation, at least in my program, and I think it's helped us. Now, I told you your patients don't get admitted electively for ECMO. They've been marinated in lorazepam before you ever met them. So you have to now break out of this cycle. And just a few thoughts that I'll share on that. Don't try to wean the Ativan or Versed off. Just stop it. Because when you wean it, first of all, it becomes very long-acting. If the patient's been on a high dose for a long time, every fat cell in their body is saturated with this stuff. So you stop it, it weans itself as it leaches out over time. But more importantly, you're going to cut it back. It's at 8 milligrams an hour, and you cut it back to 4. When you come in tomorrow morning, it's going to be 8 again. I guarantee you it will. You've all seen this happen, right? So discontinue it. Take it off of the MAR so it is not an option. Occasionally, I will replace it with an intermittent bolus of Ativan, though very reluctantly, because you just have to. It's like trying to quit smoking, right? You got to go cold turkey. That's the most effective way to do it. So I just stop it. Now, occasionally you'll run into issues with withdrawal and certain things like that. Those are different cases we have to work through. But same with fentanyl drips, by the way. Just get rid of them. Just stop it completely. And your patients are going to wake up crazy. You're going to have to battle through that, but at some point they'll become clear-headed, and you'll be glad you did it. All right, so you can't use Ativan, right? In fact, I always tell my house staff that all the patients I take care of have an allergy to Ativan. Ketamine too, by the way, for me. So what should I use? Some of the patients need sedation. What should I use? I think your best bet is going to be Precedex or dexmedetomidine. There's pretty good evidence that it's among the most benign agents we have with regard to delirium. On the left here, you see a randomized controlled trial of about 100 patients. These are all ICU patients, and they got randomized to be sedated either with that continuous infusion of lorazepam we just talked about or with dexmedetomidine. And you see at the bottom there, the Precedex patients have more days alive without delirium and coma, lower incidence of coma, and spent more time within their target range of sedation. The study on the right was done slightly differently. These are 74 patients. This is from ANZIX, the Australia-New Zealand group that has really high-quality research. These are 74 patients that were kind of ready to be extubated, but they couldn't because their agitation was requiring sedation, and it was prolonging their intubation, basically. And they randomized them to either have Precedex added or to have placebo added, basically. And again, you see more ventilator-free hours, shorter time to extubation, and a shorter duration of delirium. So Precedex is your friend. Precedex is your friend. If you need continuous ICU sedation, I would absolutely start there. Now, y'all around the ICUs a lot, you know there is a subset of patients where you put them on Precedex and you can't even tell they're on it. It might as well be water. It does not work for everybody. Propofol is probably the right drug in that situation. The level of evidence for propofol and Precedex is about the same. There's no evidence that one is necessarily better than the other. So propofol would have a similar level of support in the medical literature. The reason I prefer Precedex is it's much easier to have the patients awake. You can find a happy zone with propofol where they're calm but awake. It's much easier for me to find that with Precedex, so that's my preference. But propofol is not entirely evil. Okay, so we also need some adjuncts. If we put all the patients on Precedex, we're still going to have a significant number of patients that are a little bit agitated. and difficult to deal with. So in that case, in my hospital, we use atypical antipsychotics, particularly quetiapine. The trade name is Seroquel. And this study shows a reduced duration of delirium, 36 versus 120 hours, and less agitation. They used a different score. I used RASS, but much less agitation there with atypical antipsychotics. Now, there's no evidence that they don't treat delirium, and I want to be clear about that. But they are associated with a lower incidence in some studies. Here's what they really do for me, though. I know the patients need some degree of sedation sometimes, right? They got to tolerate an ET tube and just tolerate lying in bed all the time and tolerate hearing my intern ramble on rounds and all that stuff. So they need some sort of sedation. I need something to control their agitation. When they start really resisting therapy and causing problems, I need something to treat them with. And I haven't talked a lot about anxiety, but I need something to hopefully treat their anxiety with. Now, what other class of drugs does this? Benzos. Man, it does all three of those things. It's great, right? The difference is if I use atypical antipsychotics, I can achieve those goals without worsening the delirium. So this can help me break out of that cycle. So I don't want to overstate their efficacy. They're not wonder drugs, but they will accomplish these short-term goals for you without digging you deeper into that delirium hole, okay? Last medication I'm going to talk about is this thing called Ramelteon. Ramelteon is a melatonin-like drug. It's not melatonin. I'm not a sleep physiologist, but the people who are tell me it has some features that make it superior. But Ramelteon is a sleep aid, 8 milligrams given at night. It has been associated with significant reductions in delirium in ICU patients. In this particular study, it was 24% incidence in the people on Ramelteon versus 46% of patients on the patients that didn't get it. So that's pretty impressive. Another trial looked at Ramelteon versus placebo. We saw delirium develop in 3%, so almost none, frankly, of the Ramelteon group, and about a third of the placebo group. Now, I told you delirium is about 80% of patients. These were not all ICU patients. That's why the total incidence is a little bit lower, but the effect is still very impressive. So Precedex, Seroquel, and Ramelteon, that's the three medications we use to manage ICU, sedation, delirium, anxiety, and it's very effective. And most often, you need nothing more than that. If you do, then propofol is your best friend. Now, the thing I probably should have told you first is that non-pharmacological measures are probably the mainstay of our therapy, preventing delirium, not treating it. And that's a couple of things. Reorientation is super important, right? So every day or 10 times a day, either a nurse or a doc or a family member says, Hi, Bill, you're in the ICU. My name's Phil, and I'm your doctor. It's Tuesday. Don't you remember you got pneumonia and you're in the ICU? Okay. You have to do that 100 times a day and remind these patients to bring them back to reality. Familiar voices and people they know are very effective at that. Cognitively stimulating activities, super important. What do you guys do for cognitive stimulation? What if you were on a long bus ride or airplane? What did you do on the airplane flying in here yesterday? Any of you play on your phones? Word search, Sudoku, crossword puzzle, something like that. In 2022, patients need their cell phones. Handwritten crosswords are so 2021, right? They need to engage their mind. And in this day and age, that means a phone. The patients need their phones as soon as possible. Even still on the ventilator, they're going to text their family. They're going to do a lot of things. I think it's super important. Kind of a nod to our keynote speaker. Meditation and relaxation techniques, man, don't underestimate the effectiveness of this. It's difficult in the ICU. You kind of have to have a champion that's willing to be the person that kind of pushes that. We were fortunate enough to have a psychologist that works in our pulmonary clinic. We can borrow him sometimes. And some of his biofeedback and other relaxation techniques can be super effective and very helpful with our delirium and our anxiety problems. And then the last thing here is promote good sleep. It's super important. The alarm should be silenced or turned off. Loud talking on the night shift is a no-no. Nursing care should be decreased to the absolute minimum. So I'm preaching that to you, and now I'm going to show you what I actually do in my hospital. This is a screenshot from my radiology system in my hospital. I blacked out the patient's name. His name was Andrew, by the way. This column right here shows the time of all of his chest x-rays. Now, first of all, I'm embarrassed that we got that many chest x-rays. I usually get chest x-rays every 2 or 3 days in my ECMO patients. He was having recurrent pneumothoraces, so we got them more often. But look at the times. I'll read them to you. 4:37 a.m., 3:45, 3:56, 4:04, 4:36, 3:57. Didn't I just say to promote good sleep? Good Lord, what are we doing to these patients, right? I have another screenshot. I didn't include it here. Patient without a Foley gets Lasix at 10 o'clock at night. Brilliant. That's a great way to promote sleep. Good job, guys, right? The things we do, we underestimate the effect that they have on our patients. So engage your frontal lobe and think through these things. Now, you couldn't make these x-rays later because there's a whole hospital workflow that hinges on this, right? That x-ray tech has a pattern they take through the hospital to get everything done. The physicians want to see these x-rays, when they're pre-rounding, et cetera. So it may be difficult, but just keep it in mind. And maybe, I don't know, cancel those x-rays sometimes. We don't need them. All right, so we've talked about getting the patient good ECMO support and delirium free. Let's talk about the win now. Let's just close it out with a little bit of physical therapy. First of all, don't try to read that thing on the left, not that you could anyway. We need to have some method for assessing whether the patient is ready for physical therapy. And the reason it doesn't matter you can't read that is this is going to be different for every institution. But it needs to be systematic and reproducible. That will reassure. Your team's going to be nervous, guys. The heart rate's going to be 125. The sats are going to be 82%. The patient's going to be on a low dose of norepi. And some knucklehead physician's going to say, hey, let's get up and walk. And everybody at first response is going to be no. Okay, so if you can work this out, the staff will feel supported. They'll feel like you have their back, and you'll open some doors for yourself. So look at it, for your institution, what's going to work. It also needs to be individualized to the patient. Some of my patients occasionally will have a baseline heart rate of 120. They can do PT with a heart rate of 120. The guy who's had a heart rate of 75 for 10 days should not start a PT session with a heart rate of 120. That matters, okay? Know your patients. I would also say the urgency of rehab matters. Let me explain what I mean here. A patient that has, vomited on induction of anesthesia and aspirated and got put on ECMO. If I can't get that patient out of bed on ECMO ever, it's probably going to be okay. Some of these runs are going to be shorter, not a big deal. I don't have to push the envelope. Now take a cystic fibrosis patient who's underweight, deconditioned, malnourished, and you're trying to bridge to lung transplant on day 50 of ECMO, and they're not walking yet. That patient is going to die because they're not going to be listed for transplant. So to me, that's a different urgency of rehab. So I might be more willing to push the envelope, if that makes sense to you guys. So, and then at the bottom, as I say there, push the envelope, but don't be dumb. I have one of my favorite physical therapists, actually my favorite physical therapist. She always comes and she's like, Dr. Mason, I know what you're going to tell me, but the patient saturations are 82%. Like, thanks, Reagan. What was I going to tell you? She says, do it anyway. Okay, we agree on that. So, all right, so once we do that, assess the patient's ready. We need to go through progressive levels of activity. Don't expect the patient to get up and walk on ECMO day 1. Sometimes that happens. But it may be ECMO day 1 or 2 or day 31 or 32. But you got to start small. This is a great example. This is from, what's the name of the place? I can't remember. The medical center in Qatar. It's a very high-functioning center. This is their very sophisticated algorithm. You could use this or something like it, but the bottom line is they go from simple things like passive range of motion in bed, elevate the head of the bed, then they go to sitting, exercises in the bed, eventually they transition to sitting on the edge of the bed with the feet dangling, then they stand, then they march in place, then they walk. It's a slow process. And it's very important that you progress at the rate the patient lets you, okay? The patient is not always going to let you move as fast as you might want to. All right, a little bit about starting small. Patients' families can do this. There's some resistance bands on the left. I have a pillow under the patient's knee, and the family is assisting the nurse here. They're holding up against that resistance band and letting it come down. Great way to build quadriceps strength while a patient, before they're ready to get out of bed. And on the right, something similar there. That's just ankle weights. By the way, look at her bed rail. You see that right there? Can you guys see that? You know what that is? That's one of those little stretchy resistance bands. So we do the same thing with upper extremity strength. The patient can sit there and do this on their own time. They don't need you to be involved. So just little things like this may not seem like much, but this is how you're going to take that patient from their debilitated state to ultimately walking down the hallway. Sorry about that. So just a couple things here. On the left, once you get to that point, you want to go through progressive challenges and work your way up. On the left is a tilt table. Okay, that patient, that's just a rigid flat table. And the patient has a really broad band or a strap across their knees, so their knees can't buckle. And we start him at 10 degrees, then 20, 30, 40. That'll go all the way up to 90 degrees. So he's bearing a lot of weight on his legs, but he's protected because the knees are kind of pinned back against the table, if that makes sense. But what we're also doing is we're familiarizing him with this concept of gravity. Okay, a lot of changes happen in your body when you go upright. So this is a great way to work your way through that progression. Oops, I don't know why that video is not working on the right. There it is. This is one of my favorite patients, David. That's what we call a Moveo table. It's a squat table, allows the patients to do progressive levels of squats. We can do it at 10 degrees, 20, all the way up to 45 degrees. And obviously, the higher we go with the table, the more resistance the patient has to exert, or the more force they have to exert, and you can work your way up this way. It's very safe. The table's blocked, so he can't collapse and fall down, and it's a really nice way to work your way up to a strong patient that can ultimately stand up. Okay, guys, just a little bit, I like to kind of have a lighthearted approach to most of the things maybe you guys noticed, but just a final thought that I'll share with you is don't underestimate the effects of human interaction. Man, that was tough before COVID. With COVID, wow, man. I mean, N95 masks and face shields and visiting restrictions, it was a mess. But don't underestimate how powerful this can be. I'm telling you this because it works, and I'm also telling you because I want to brag on my team a little bit. This girl on the left right here is braiding her hair, okay? That's free. There's no side effects. Nobody's allergic to it. It's very easy, okay? She's braiding her hair. This is a guy, Adam's his name, great dude, ultimately survived his 90-day ECMO run for COVID, and he had horrible anxiety, and he wanted somebody to hold his hand. And here's this guy. He's one of our techs that would just spend his lunch hour sitting there holding the guy's hand. Seems kind of silly, maybe. I don't know. It works. On the right, I'm sorry I took that picture through a glass window. You can't see it. But that's another one of my techs giving a patient a temple massage. Okay? Silly things. I'm telling you, it doesn't cause delirium. It treats delirium, and it's very effective at treating anxiety. So don't underestimate the power of human touch. Oh, and dogs also. Don't underestimate the power of dogs. We use a lot of dogs in our program. This little guy right here may or may not have been smuggled up a back stairway in a nurse's purse. Yep, I know. I don't want to offend anybody. I don't normally see the use for a dog that small. I just don't. I have a big lab. But if you're ever in the hospital on ECMO and you want your dog to come in, well, I don't know, having a little purse-sized dog may be helpful. No, that's not Paris Hilton that had the dog in her purse. And then this is we do this a lot, actually. This is the family dog, and we have the patient's family bring the dog to the hospital, and then we take the patient outside so they can see the dog. I'm telling you, man, it makes a huge difference. And I'll tell you one more thing. If your patients quit, if the patient gives up and quits and stops fighting, you are done. It doesn't matter how good you are. It doesn't matter how good your team is. If the patient doesn't stay in the fight, then the fight is lost. And little things like this will go a long way and are way more effective than all the medications in the pharmacy. Okay, guys, that's all I have. Thanks for listening. Happy to answer questions. Yeah. Absolutely.
So for time-wise, we're going to, Dr. Mason will include